Ladies and gentlemen, welcome to evening by Ludhiana Management Association. We have very distinguished gathering and very distinguished medical practitioners and best doctors among us today for awakening us about public health, about how we can take care of our health systems. This is a very special evening for us all today. Before that, I would like to welcome Dr. Prabhakaran Dorairaj on the dais, our special guest for the evening and special speaker. Thank you, Dr. Sir. Ludhiana Management Association was formed in 1978 as an affiliated unit of All India Management Association, New Delhi, with the initiative of management academicians, senior executives and industries. The objective was to enhance competence of member organizations through management education, to provide training and development to entrepreneurs and executives at all levels, and to interact with top-notch industries and CEOs to provide a platform for management professionals and entrepreneurs to discuss their issues. The landscape is that over the period it has come as one of the most outstanding and fastest growing management association in Northern India, with closely 600 leading industries, entrepreneurs, top management executives, management academicians, bankers and professionals. LMA has been conferred with Best LMA Award twice on an all India basis. Some of the past presidents of LMA have been the eminent industrialists. Two past presidents, namely Shri Brij Mohanlal Munjal, Chairman Hero Motorcorp Limited, and Mr. S.P. Oswal, Chairman Workman Group, have been awarded with Padma Bhushan, while past President Mr. Rajendra Gupta from Trident Group has been awarded with Padma Shri. Mr. Sunil Kant Punjal, Chairman Hero Corporate Services Limited, has also been the past President of CII. Along with me, I have today Mr. Neeraj Jain, Joint Managing Director Workman, who is the President of Ludhiana Management Association, and Mrs. Harpreet Kaur Khan, Dean International Studies from PCTE, Punjab College of Technical Education. Some of the past keynote speakers have been His Excellency Dr. APJ Abdul Kalam, Dr. Manmohan Singh, Shri P. Chidambaram, Shri K.P. Kamath, Mr. Anand Mohindra, Mr. T.N. Session, Mr. Arun Jaitley, Shri J.J. Irani, Mr. Shekhar Gupta, and the list is quite long. His Excellency Honorable Governor of Punjab has always been kind enough to be the chief guest of the annual function of LMA for the last 28 years. That is about Ludhiana Management Association. Before moving forward, I would request Mrs. Sachit Jain, Vice Chair and Managing Director, Vardhaman Special Steels, to give away a token of love to our special guest. May I request you, sir? Thank you so much, Mrs. Sajid. May I now request Dr. Hero DMC Heart Institute to welcome and introduce our guest speaker.
Thank you very much. I think I don't need written because I know him. I was his student in All India Institute. And it is a Teachers' Day. So I think you can see that how fortunate I am that I am something very unusual. In fact, it's a chance because Dr. Wonder has to introduce. I'd say that Dr. Prabhakaran is a graduate and he's did DM Cardiology from All India Institute, and he was teaching when I was doing my DM program in All India Institute. That was the time when cardiology was at the prime. You can see that in 95, 96, hardly dozens of cardiologists all over the country. And it was very attractive and you can say very big job to have a cardiologist. And he has worked with the Prime Minister, he was in a PM office also at that time. So, but suddenly his thought was to do more for the society, not for just few numbers doing interventions or looking at the patient even in All India Institute. He thought of doing something bigger. So he left that job and he became something different at that time, which we know from COVID that how important is public health. So he became, follower of public health at that time. And at that, it's been 20 years. So after that, there is no looking back. He did wonders for the country. So I can just say two important things. That he is one of the most read author from India. So that's a big achievement. He has mastered in number of, experimental, I would say social experimental innovations. So we are going to see that. These innovations and research. So he had given a new dimensions to people like us, that you can do a social service, public health, as well as even a world-class, research. So we can imagine, we all know about Lancet, New England Journal, JAMA. Most of us know, even all, because in the last couple of years, these journals were at the forefront. They are the best of the journals. So even the editor has taken his interview, that how he did behave in his life. That's a great achievement for any person from India to have. I am not going to tell what position he is holding because there are innumerable positions. He is a professor in one of the best institutes all over the world, UK, USA, and he is the director of Center of Control of Chronic Disease. He is a vice president of Public Health Foundation of India. So there are a number of things. But one thing I just wanted to share. We always discuss about the yoga. We all know that yoga is an ancient science and it is very helpful. He is the person who has brought yoga care after heart attack on the world map. This was presented in the Chicago in 2020 and it was widely circulated all over the world. Unfortunately, the COVID struck, but most of the people came to know that the evidence-based simple yoga care from this man and his team. So great honor for all of us. So I would request Dr. Prabhakaran to have his thoughts and his favorite lecture, that innovations for the community health. Thank you very much.
Thank you, Michelle, for that very kind but exhaustive introduction, and a very good evening to everyone, and thank you for all of you to come and wait for this talk. As Michelle was talking, I was looking at a comparison between him and me when I was young and I was a physician and a cardiologist. One thing which I can tell you, I can't match his energy, because energy is, you really cannot match. But one common theme was, what's the difference between a cardiologist who treats patient and a cardiologist who's moved on to population health like me? So I just want to tell a story of a small boy who was standing in front of a large ocean, and the waves hit the ocean and some starfish came onto the sand, and this boy was lifting one starfish after another and putting it back into the sea. So one man who was standing close by, he said, a young man, what are you trying to do? This is a vast ocean. How can you make a difference by just putting this one or two fish back into the sea? So the boy replied, I am making a difference to that one single fish. And similarly, Vishamohan has made a difference to innumerable such individuals. So as a population scientist, I was a cardiologist for 15 years and I did try to match Vishal. I don't know, he has to say how I perform. But after that I moved on to looking at population health and trying to work towards prevention of cardiovascular diseases. I always stand with reputation when I have a mixed audience. It's easy to talk to doctors, it's easy to talk to a general audience. But when you have a mixed audience, it's difficult because doctors will think, this is very simple, I knew this, what is he trying to talk? So my apologies to doctors who know everything, but I'm just going to give my talk on how to prevent chronic disease in India. I'm going to talk on 4 themes. What are the chronic diseases that we need to think of? What is the role of diet? What is the role of physical activity? What do we do to people who already have a disease? And what can we do in terms of innovation to reimagine our health system so that we can reach as many people as possible? Ease their visits to the hospital, they take a lot of time. How do we reduce the time component for them? How do we provide quality of care? And how do we improve outcomes? And I'll try and finish and won't bore you with too many details. So what we call as chronic disease or non-communicable diseases are a big public health challenge of the 21st century. Why? Because worldwide, even in the poorest country, they cause nearly 2/3 of the deaths. That's number one. And when you combine it with climate change, it is a real catastrophe. So we really need to do something about this. And can I just write that? So both are threats to economic growth and sustainable development. So originally we had what is called as a 4x4 paradigm, which was defined by WHO. That 4 risk factors caused 4 diseases, which increased the risk of death. In fact, there was a website called 3450. It means 3 risk determinants: diet, physical activity, and smoking caused 4 diseases: cardiovascular disease, cancer, diabetes, and lung disease, resulting in 50% of the deaths worldwide. So it was a simple message that if you tackle these 3 risk factors, you can tackle 50%. But the WHO moved on because the UN, United Nations, met. United Nations keeps meeting about peace and about wars and things like that. In terms of health, it has met only twice. The first time was in 1993 to address the big epidemic of HIV that was there at that time, and that resulted in a substantial amount of funding, which actually has led to a decline in HIV. The second time they met was for NCDs, for non-communicable diseases, because they realized the huge economic losses because of non-communicable disease, and something had to be done. Not only economic losses, it was losses of lives at very young age, productive period of life. Therefore, something had to be done. And that time, we came up with this 5x5 paradigm, which means 5 major non-communicable diseases, that is cardiovascular disease or heart diseases, cancer, respiratory disease or lung disease, diabetes, and to this they added mental health conditions. And they linked this to 5 risk factors, namely tobacco, unhealthy diet, physical inactivity, alcohol, and air pollution. Of course, one might argue, why did we leave out liver disease, kidney disease? There are several others. In fact, we should take it into consideration. But if we look at prevention paradigm, and if we can prevent these risk factors, including air pollution, we will be able to cater to all the diseases that are mentioned here. The other point that I want to make is heart diseases constitutes nearly 50% of all chronic diseases. And therefore, it's important, if you have to start from somewhere, we should start with heart diseases. So just to give you some numbers as to the rapidity with which the numbers are rising. So every now and then we make projections. In 2017 we had a certain number, and we said by 2025 India will have this number. So in terms of diabetes, in 2017 we had around 68 million people with diabetes, and it was expected to increase to 134 million by 2025. But in 2021, it had already reached, this is according to a latest publication from Dr. Mohan and his colleagues from Chennai, it has reached 101 million. But look at hypertension. It was 207 million, and it was supposed to increase to 214 million by the year 2025. We have touched 315 million in the year 2021. It's already risen. So we are actually sitting on a ticking time bomb. Obesity has increased substantially. The only good news for us is tobacco, that is smoking, has shown a decline all over India, and I believe in Punjab it's not such a major problem. So what constitutes cardiovascular disease and what determines it? So we all know that cardiovascular disease comprises of heart attacks, strokes, angina, that is if you develop chest pain or walking, and it has risk factors such as hypertension, diabetes, and tobacco use, heart failure. So these are some of the things which are listed there, and there may be a few others, but they are not as common as these conditions are. So the question that we need to pose is, after all, we have seen advancement in science. We have pharmacoinvasive therapy. I was talking to Vishal today morning. He said in Punjab we are giving a drug called tenecteplase, which opens up the clot. It's a clot busting drug. We have advances in angioplasty. We can open up any artery, even the most difficult artery we can open up. We have advances in surgery. So why should we be fighting? Why should we prevent heart diseases? So that's a question which we need to pose. The first thing is that we have to say is that nearly 1/3 of deaths due to heart attack occurs at home or in the workplace before people can reach the hospital. We need to prevent that 1/3 of those deaths. And the other big problem is it occurs in the younger population. We call it as premature mortality. When we look at Western societies, most of the heart attack related deaths occur after the age of 70 years. Only 20% of the deaths occur before the age of 70 years. Whereas in India, it's around 56% of the deaths. And even if you take 65 years, which is the retirement age in most places, the number of people who die because of heart attack is close to 45%. And they are dying during their productive years of life, and we need to stop that. And that's why you require prevention. Then there is economic process, because it happens in the productive years of life. So these are data provided by the Harvard School of Public Health and the World Economic Forum, and they estimated over a 20-year period what would be the economic loss for India. This is India alone, it's not the world. $4.58 trillion. And just to give a perspective, what is the GDP of our country? Sorry?
Less than that.
Yeah, it's just crossed somewhere around 3. So that's the kind of problem that we are facing. There is a special predilection for cardiovascular disease. Indians somehow have higher predilection to develop diabetes and cardiovascular disease. Some forms of cancer, oral cancer is very high. Gallbladder cancer is high in the states of Mizoram, even Punjab, Delhi, and this belt has higher proportion of gallbladder cancer. So there are certain cancers which are high, certain risk factors like diabetes is very high. And of course, the recent entrant into this mix is air pollution. Just to give you a perspective, the WHO states on an annual basis, PM 2.5, by which we measure air pollution, should be less than 5. It's 100. And what is our national air quality standards? It's 40. We are nowhere near 40, forget getting close to 5. So that's a new method. Indoor air pollution continues to be a problem despite the Ujjwala scheme of the Prime Minister, because people are using it for other purposes. We need behavior change there. People say that food cooked with firewood or other kinds of fuel tastes better than food cooked in gas. So these are the kind of problems that we face. Then the second thing is there's a lot of urban to rural to urban migration. migration. People from rural areas constantly come to urban areas looking for employment. And when they reach whatever their level of socio-economic status may be, they develop cardiovascular risk factors within 10 years of migration, and they almost become like urban residents. So they have a double whammy. They have developed cardiovascular disease and they are poor and they cannot afford the treatment. And there is a progressive reversal of socio-economic gradient, by which when you look at the history of heart diseases across the world, it first affects the rich. It first affects the educated people. Then it starts affecting the middle class. Then it starts affecting the poor. So much so in countries like United States, Canada and UK, it's the poor who develop cardiovascular disease. In India, some parts of India, we are witnessing that. Actually, the reversal has already happened. And therefore, all these make a good argument for prevention. Now, the next question that I want to answer is, what are the myths in terms of heart disease? In 20 years back, I think, Dr. Wonder, I don't know whether you remember, 20 or 25 years back, there was an article in Lancet. Dr. Reddy wrote an article saying that we need to invest in cardiovascular disease. And the health, I think he was the director of health in World Bank, he wrote back saying that it will be a distraction. If you invest in non-communicable diseases, it will be a distraction for poor countries, because the belief was that heart diseases are diseases of the rich and the rich amongst the poor countries. Therefore, we should not invest in non-communicable diseases. And that has changed. It has taken 20 years of advocacy to change that. Second is, many people say, even if I get a heart attack, so what? The advances in medicine will cater, but as I said, only 1/3 of the patients actually reach with a heart attack, 1/3 die, and the remaining 1/3 come with other forms. They don't have chest pain, they have breathlessness, and they're identified late, because of which they develop heart failure. So clearly, who benefits is only 1/3 of the patients who have a heart attack, 1/3 die in the field, and 1/3 suffer from complications, and therefore we need to do something about it. I just was talking to someone who said, I'm a vegetarian. Why is that there is a risk for heart attack for me? And my friend, my colleague was a vegetarian, was a teetotaler, but developed heart attack. So let's discuss what this means a little bit later. I've had a heart attack, I'm fine. I can take care of it lifestyle, I don't require medicines. And this is another big problem. One, because of the fake messages that come through WhatsApp, because there are a lot of these self-styled gurus who keep telling that you don't have to take medicine, it's all conspiracy by the pharma companies and by doctors. So that myth has to be busted. And many people, if you ask later, they say most important cause of heart attack is stress. Nobody knows what exactly stress is. It's not a definition, but that's not the kind of stress definition which people use. So there are several myths which require to be busted. So first, let's handle diet. Diet is linked to heart attacks in many ways, and we know each person. There is a story which Buddha told a woman called Sujata. Her son died, and somebody said Buddha is a person who can bring him back to life. So she came to Buddha and said, I don't know how they called him, said, Swamiji, my son has died, please bring him back to life. He said, yes, I will do that. But go to every house and find out in one house where there has been no death and bring some mustard seeds from it. So she went and she could find, if you do a similar experiment, you will have in this whole audience, there will be at least one person who you know who's had a heart attack. Right? And so you get celebrities and others who have had heart attacks and strokes. So diet is linked to heart disease in many ways, through heart attacks, strokes, diabetes, high blood pressure, obesity, and other complications. So I again would like to narrate a story from Mahabharata. So Mahabharata is divided into 18 chapters. There's one story which is the forest of Pandava Prashna. In that, a king does yagna and feeds Agni with a lot of ghee. So much so, he becomes very listless, tired, and has lassitude, and goes to Brahma and asks him, what should I do? I'm feeling all these problems, I'm unable to move. So Brahma says, you go and eat the Pandava forest. So what's the message here? That moderation is important for carbs, and we need to eat green leafy vegetables. Then coming back to the vegetarian issue, there is something called the South Asian paradox. We did a study and compared Americans to Indians in terms of their diet. You can see the number of people who are vegetarians in the US. It's pretty small. Large number of people are vegetarians in India. Our population, the study that we conducted, 38%. Look at the prevalence of diabetes. Why is diabetes prevalence so low in the US and why is it so high in India despite the high proportion of vegetarianism? So the reason is, I would call this contaminated vegetarianism, because vegetarian in both populations had a lower probability of developing, but Indians had a much higher probability of developing as compared to the US population. Vegetarianism protected against central obesity, but there was a stronger association with US vegetarians. And why was this? This is because what we have is a contaminated vegetarianism. We consume deep fried foods which have a double ban. They have high trans fats and are extremely dangerous because they have loaded with sugar and they have high trans fats. When we heat oil to 1000 degrees or so, the good fats are also converted to bad fats. The trans fats are very powerful in terms of increasing your atherosclerosis, which is the process by which you develop heart attack. And that's one of the reasons. The second reason is most of the vegetables and fruits which are consumed in the West are consumed raw. We overcook the vegetables and boil them and beat them all the good nutrients to death. So that's the second reason. So the way we cook, the kind of vegetarian foods we eat are actually one of the main reasons. So whenever I think of sweets as a cardiologist, I love that sweet. It's called Mysore pak, which is a famous sweet in South India, in Tamil Nadu and in Karnataka. Just love that sweet. But when I eat one, I think, is it Mysore pak or is it going to cause Mysore plaque because I'm from Mysore? So whether it goes directly and gets deposited in my artery. This is a picture of the LDL cholesterol, which is the bad cholesterol. And when you look at the laddus, especially the motichur laddu, it almost looks like LDL cholesterol. So when you eat Indian sweets, you need to think of these things. So this is a bit of a short tour on diet. There are lots of things to talk about diet, but that's for another day because I would take away the whole night and impact your later nutrition. So let's talk about physical activity a bit. Everybody says smoking is bad. Indeed, it is bad. But physical inactivity is as bad as smoking. Right? And the WHO has estimated that smoking causes almost 5.1 million deaths every year in the world, and physical inactivity causes almost similar number of deaths. Physical activity decreases the unhealthy fat in the blood. It has a capacity to decrease cholesterol. It won't decrease as much as statins would do, but it decreases the lipids and increases the good cholesterol, which is the HDL cholesterol. It also has a potential to decrease the blood pressure, to decrease body fat, to decrease abdominal obesity, and it protects you against osteoarthritis, breast cancer, and several other problems which people face as they grow old. In fact, it's one of the best treatments for mental health illnesses, particularly anxiety and depression. And one might say that where is this evidence? And there are substantial evidence. There have been studies in Finland, in China, in US, and many other places, which showed that just increasing your physical activity to 30 minutes of brisk walking every day for 5 days a week is cardioprotective. It can protect your heart. So even incidence of hypertension can be reduced with good physical activity. The best example is our Dr. Kishore Mohan, who does a lot of cycling and walking. Sitting is a new risk factor. It has been suggested, if some of you have this hi-fi Apple Watch, every hour it tells me to, if I'm sitting, to stand up at least for 2 minutes. So sitting continuously for 8 or 9 hours period is as bad as smoking, So one needs to get up for 2-3 minutes every half an hour to 1 hour. And in many offices in the West, people actually work standing. So that's the importance of not sitting. So I just mentioned this, that what we should do, we should exercise, we should do aerobic exercises, the simplest of which is brisk walking. In addition, we should do some stretching exercises to increase our muscle tone at least twice a week for 5 to 10 minutes. So these are 2 simple things that we should do in terms of physical activity. Now, this I put together actually 2 hours before because I didn't realize that it was a management association to which I'm going to give a talk. Employees live with at least one chronic condition. If you do a survey in work sites, 60%, this is an old figure, this was a figure from 2005, but I think recent figures are diabetes, and more than 1 in 3 employees have pre-diabetes, which is a precursor to diabetes. So somebody has pre-diabetes, they haven't developed diabetes, but they will develop diabetes within the next 5 years. So, huge problem in terms of chronic diseases. Are there evidence to show that worksite interventions improve? Unfortunately, what happened was in the late 70s and 80s, there was a study which was conducted, which was funded by WHO. It was conducted in multiple countries. And they looked at a worksite intervention program. That study was neutral and people gave up doing anything at work sites. But there were a lot of flaws in the study. The dose of the intervention was low. They never consulted the worksite employees because anything which goes top-down doesn't work. So we need to co-design the intervention with the people who are working in the worksite. So there were a lot of other flaws. But now we have learned that we can actually work to improve the worksite wellness. Sorry for this slide. So the message of this is that worksite programs do work and there are some evidences that they work. Preventing diabetes, I'm taking the example of diabetes, but we could prevent other diseases. It makes good business sense because A, it reduces absenteeism because it reduces the periods in which they are ill. It also reduces what we call as presenteeism. They come to the work site but they don't work because they are ill. They develop complications, so it reduces the cost to the organization. So it really makes good sense and it increases productivity. Therefore, we need to intervene at least in terms of 1 or 2 risk factors in our work sites. So what is the role of employers in diabetes prevention? I was talking to, I think, Mr. Jain today, and I said, or was it in the morning, I can't recall, where we said that when is a worksite program successful? If the CEO of the company gives the first blood sample and takes part in the program, they are influencers in the company. So employers have a major role in improving the wellness of the people. Employers and partners in the community may have a role in addressing these factors to directly employ and you involve the families. Because it becomes very difficult if we have a person with the disease, with diabetes, and we say you should not eat this, you should not eat that, you should do this, you should do that. If the whole milieu in the family, if the whole milieu in the industry is catering towards a diabetogenic diet, what will the poor person do? So we need to create an atmosphere where there is a system level intervention, where everybody is eating healthy, everybody is thinking of health. We also need a cross-sector partnership because so far we have left the serious business of health to doctors. Never do it. Like economists should not handle economy alone. It requires a village or a multidisciplinary team. So create those multidisciplinary teams. So what's the role of business in public health? So they have various roles like in consumer health or products and services, safe and healthy. In terms of employer health, do we have the policies, benefits and environmental supports in place to positively impact employee health and well-being? In terms of community health, actually we have corporate social responsibility, so around the community can we do something? And in terms of environmental health, what programs and policies can enact or support to protect people and provide communities with a healthier environment? So unhealthy workforce means unhealthy community. There are 30 million people in the organized sector and close to 100 million people in the unorganized sector. So Very unhealthy workforce means unhealthy community. Healthier employees plus a more productive workforce is a strong local economy. So we need public-private partnership in terms of improving health. So we need to look at many things. We need to look at impact. We need to provide resources, and we need to have an alignment with the overall health of the population. I'll just leave this out. So I'm just going to show this example, which was done in the United States, where they did a very simple program saying that you should participate in a program, in a group program, and try and reduce your body weight by 5%. Like if you are 70 kgs in weight, get your weight reduced by 3 kgs. And they showed a 38% reduction in the incidence of diabetes over a 5-year period. Now, interestingly, in the same study, they gave metformin, which all of you know is an antidiabetic drug. Metformin was also very similar, or it was little lower than the lifestyle change which they promoted. So clearly lifestyle, particularly for prevention, is very powerful. But the problem is the uptake is poor, so we need innovative strategies in terms of delivering these lifestyle advice. So we try to replicate this program. I mean, this is what we call as a meta-analysis. We looked at 10 studies put together and showed that it is beneficial. This is the impact of the worksite program which we did in 6 industries between 2001 and 2006. This is published in the Journal of American College of Cardiology. It's cited as one of the best exemplars for worksite intervention by the World Economic Forum and the Institute of Medicine, Washington. So when you look at the intervention sites, which were 6 industries, you see all the risk factors are gone down. Only one risk factor, which is the good cholesterol, has gone up. In the control industry, you can see everything has gone up over a 5-year period. This intervention we costed at that time was 350 rupees per person per annum for each of the industries. This had system level interventions. One, they made canteen level changes if they had a canteen. So the 2 simple things which we advised them was, we went to the kitchen, we spoke to the cooks and told them, how do you do your tadka? They said, we pour the oil in. So we said, why don't you measure it and pour it? When you measure it and pour it, you get a sense of how much you are doing. Second thing is, we said, why don't you give a good, healthy choice for your desserts? We said, only these 2 things. In terms of physical activity, we said there are staircases which people are not using. Just clean it up, make it attractive for people to use, and tell them at least for 2 flights of stairs they take the staircase, for the others they can take the lift. The third is, we requested them to give some time off. And fourth is, we said they should get screened for risk factors, and then they should get treatment. And this is what happened at the end of 5 years. And similar, I mean, this is a thing which is showing the difference for by age and the other impacts. This is again by tobacco use. We wanted them to reduce extra salt use, and food consumption increased, and leading physical activity also increased. So this led to us this program which we recently finished called India Works, and we conducted this program in 11 industries across India, in 5 states, in Kerala, Tamil Nadu, Chhattisgarh, Orissa and Jharkhand. And the idea here was not to do a trial and show that it works. The idea was, how do we implement and show that we can actually prevent diabetes? And so this, at the end of, despite COVID pandemic, we were able to show that 1/3 of the people who, because when we started out, we started with people who had hemoglobin A1C more than 6.5. That is, people who had diabetes, and people who had more than 6.5 were recently detected, and people who had more than 5.7. When we did the final analysis, nearly 1/3 of the population, people who had HbA1c of more than 5.7, which indicates pre-diabetes, 1/3 of them were below their values. All they did was, they had these group sessions for 16 weeks. The HR participated. It was blessed by the CEOs. We trained the 1 or 2 people from the HR. They trained the other employees. They had to attend 12 to 13 sessions where they discussed as to how they follow a healthy lifestyle, what they did, and there was diffusion of information amongst people. And at the end of 5 years, we found that people who were considered pre-diabetes had gone back to normal glycemia and had normal levels of blood sugar. So this is the power of simple interventions with small incremental changes, but delivered in such a way that it is attractive and we can follow these. It also had benefits on mental health. A lot of people reported less anxiety, particularly during the COVID time, and some of the people who had depression said they felt much better and their medication usage had reduced. So delivering lifestyle programs at work site can be effective using the existing structure of the working health facilities, so you don't require gyms in your work site. Simple things can happen. Utilizing trained work site staff as peer health educators, overcome many individual level barriers to participation, lack of time and social support, because especially when you're doing it with groups, with your friends, you find it more attractive. And higher employee satisfaction, retention, and possibly less lost productivity due to illness. So these were beneficial to the employers. So the management support is what is required if you have to conduct good worksite programs. So I'll leave this out. So to conclude, worksite-based prevention program can delay onset of hypertension and diabetes, improve work culture and reduce absenteeism, and promote employee health and quality of life. And role of the worksite management is crucial. And worksite-based interventions can help eliminate many employee-level barriers and build a sustainable environment for healthy lifestyle. In fact, today morning I was talking to the Ministry of Health. The Minister of Health was there, Punjab, and there were several secretaries. And one of the things I said, in terms of innovation, we should take some of the management principles of the industry and apply it to healthcare. And that actually can help in terms of quality of care. And because we are working in silos, the health doesn't talk to the industry, and so there's a lot to learn from each other. Now moving on, I thought I'll talk about one or two innovations in the next 10 minutes or so, and I'm going to basically touch on digital technologies, frugal digital technologies, and how it can improve access and care. So I'm going to talk about telemedicine. A lot of technologies that we've worked on, but I'm going to talk about telemedicine because it has a huge potential in reducing, in improving access, but it's also a huge mitigator of air pollution. People don't have to come to the hospital. People don't have to, and it reduces the number of resources that are required in terms of supply chain issues. It has been suggested it's a good program for climate change, to reduce climate change. It improves the role of access, and I'm going to show one platform that we have developed. What we have done here is we have created an interoperable platform. Most of you know that some of you have iPhones, some of you have Android phones, but these phones don't talk to each other, and it's very difficult. Similarly, there are platforms that are being created which will work only with a particular set of instruments. So we have created an agnostic platform where we can stack any technology, we can extract that information and put it in a software. So we have developed electronic decision support system for management of personalized management of patients. What do I mean by this? Suppose in my clinic a patient walks in, he's say 50-year-old man. He has blood pressure of 160 by 100. He has asthma. He's a non-smoker. His weight is good. His diet is good. He's physically very active. So a nurse who's trained to take that information puts it into the system, and we have put in around 2,500 case studies in the back end, and we have trained through machine learning algorithms for the system to give a diagnosis and an advice. At the end of it, the system provides a printout and says, this patient has got stage 1 hypertension, advise 1 unit of ACE inhibitor and avoid beta blockers. So what happens here is when it goes to the doctor is reminded this patient has got asthma, I should not give beta blockers, which can cause a problem. So errors of omission and errors of commission are avoided by this system. Second is we have a point of care device with which you could do multiple tests. This is little outdated. Now we are working on new systems or trying to put in, get systems from others where you can get 5 or 6 simple tests. Earlier what used to happen, patient goes to a doctor, the doctor advises a test, they go to the lab, then they get the report after 1 or 2 days. How much time is wasted? So you could do a point-of-care device as good as a lab and get the report on the same day. The third is we paired an AI-enabled ECG, which gives you a diagnosis. It should be verified by a doctor, of course, but it gives you a diagnosis. We have paired with a digital stethoscope where a doctor sitting thousands of miles away can hear a cardiac sound and a respiratory sound, and in fact can follow up by looking at the recordings. We have a high-definition camera which is operated by the doctor remotely to examine the patient. But we are adding many more things, like we are working with Arvind Eye Care to look at refractory errors, to look at retinal photographs for retinal problems. So you can actually stack any new device that you want. So we piloted this in Tamil Nadu. In fact, it is there in two places in Tamil Nadu, one in south and one in north. We call it a designated telemedicine center. The problem with routine telemedicine is patients are not very literate, number one. Number two, patients are not digitally literate. So they are unable to fathom where to go. Second, the doctors sitting on the other end are frustrated because they don't have enough details. It's a patient who's giving the detail, take a lot of time. So to avoid all of these, we have this designated telemedicine center where we train nurses or community health workers through digital technologies. Like for example, we have, I'll show you the dashboard, where the patient comes with fever. So there's a drop-down menu which says how many days of fever, is it continuous, is it remittent, is it intermittent, how does it come down, do you take any tablets to come down, is it accompanied by a headache, body ache, and so on. So all that data automatically gets in, they don't even have to enter, it's just a click. Similarly, physical examination, we have trained them. And some basic physical examination they can do and report it to the doctor. So all this gets into the system, they have a consultation, and if they have to have a specialist consultation, they have a specialist consultation. Now we are working on a mode where they will be paired to an e-pharmacy, where drugs can be delivered to the patient's house. So the beauty of the system is what would take 2 or 3 days for the patient will be over in 2 to 3 hours. I mean, this is a very idealized situation, but even with the worst case scenario, it should not take more than a day. Secondly, there are a lot of people who are unable to go to the hospital. It requires a special ambulance or somebody has to carry them and bring them. So we can do on-foot telemedicine assistance, and we have shown that it works. One might ask, what about the internet bandwidth? The system that we have created can work on low bandwidth because we know that in many places the bandwidths are low. It can work on a 4G telephone. For far-flung places, we are going to work with HelpAge India in terms of providing telemedicine assistance to the elderly population using those kind of vans where we set up the telemedicine there. And in the future, we are going to set up kiosks which can be used. It can be carried in a suitcase and you can use it anywhere, in a railway station, in a mall, in a theatre, wherever you can set up a telemedicine. The idea is to improve access and provide quality care at the least possible time. So this is how the dashboard looks like. For example, a history template is there, the person is trained, there's a decision support there in terms of what questions to ask. There is a physical examination. Then there is longitudinal data which is provided to the doctor, so the doctor can see, instead of looking at multiple papers to see 1 month back what is the blood sugar, what is it now, 3 months back what was it, it automatically gives that data. Then the lab data is provided. Then we have the ECG, then we have e-prescriptions, then we have a follow-up schedule which is done by the system and provided to the nurse. I don't know whether we can hear the sound. Let me see. No, because it requires a different mechanism. So the nurse is asked to keep the stethoscope at a particular place and we can hear the cardiac sound beautifully being far away. Similarly, you can hear respiratory sounds and you can see the variation. So this is a virtual clinic created with a very simple system. And these are the data over a 2-year period. We have seen more than 23,000 patients. We have paired it with community engagement. We have paired it with camps. And we have provided care beyond cardiovascular diseases. It included eye disease, it included orthopedic diseases and many others. And I'm just showing you an example of blood pressure reduction. In this group was almost 6 millimeters of mercury, which I think is fantastic. Even clinical trials just give you around that kind of results. So telemedicine has the potential to bridge the gaps between the community, technology and digital healthcare through trained personnel. It can provide continuity of care and longitudinal health data through use of inbuilt electronic health records, and can create an innovative model for health service delivery that enhances sustainability, accessibility and affordability of care. What about people who have disease? What can we do to them? We now know that there are 4 simple drugs that can be given. But what happens in reality? What happens in reality? When we give these 4 drugs, it has the potential to reduce 75% of repeat heart attacks or stroke. But in reality, what happens, it boils down to only around 20% benefit. Why? There could be errors of commission by the physician, the patient may not be taking, it may be too expensive, there are multiple problems. And there are simple solutions to it. And one of these solutions is what we call as a fixed dose combination. Because patients say that it's like eating food, I'm taking 10 tablets at a time. But can we put it all together in one simple capsule? It's a complex process, but can be done, and it has been done, and we have demonstrated that it works. The problem is there is resistance from medical professionals, from industry, because if you pack generic medicine and give it to them, it is much more beneficial than the usual care that is provided. In fact, it's around 50% better than the usual care. So these are the kind of innovations that we need to look at in terms of doing. And last is the other end of prevention, what we call as rehabilitation. People have the disease, but they have to be rehabilitated. Cardiac rehabilitation is a program which is very useful in patients with heart attacks, heart failure, and many of the heart diseases. But in India, there are very few places which give cardiac rehabilitation. The big problem with cardiac rehabilitation is expensive. You require a room as big as this, you require multiple equipments, you require a physician, a nurse, a nutritionist, a physiotherapist, and so on. But we thought, can yoga provide all of these? And so we did a trial and showed that it's beneficial. We have demonstrated it in diabetes, we have demonstrated in cessation of tobacco use, and to some extent in reversal of lifestyle package. The big problem about yoga is a lot of people think yoga is just one piece. There are people who say that it is the yogic posture which is important. The Iyengar yoga emphasizes the yogic, the exercises of the asanas. When you look at Baba Ramdev, he emphasizes the importance of breathing exercises. When you look at Sri Sri, he talks about meditation. But when you go to the ancient yoga texts and look at what is called as Ashtanga yoga, which has got 8 principles, it actually starts with the environment. First is it says keep your environment clean, so we need to address air pollution. Second, it says clean your internal environment with right kind of diet, so we emphasize lifestyle. Third, of course, is the physical postures, then mindfulness and meditation. Then, of course, there are a few others that includes education and the right life, and ultimately the samadhi, which is the final thing of yoga. So we have created a heart-healthy yoga package, and we are delivering it in terms of heart care. We are actually conducting a trial we did this trial, and we showed improved quality of life, early return to pre-infarct activity. That is, how much time does it take for people after a heart attack to go back to their original activity? With yoga, it was much earlier. And there is some mortality benefit, but it didn't reach statistical significance. And it was one of the largest yoga trials in the world. In fact, we had 4,000 patients. Right now, we are doing a trial of yoga in patients with heart failure, and that will be completed in around 18 months. The last thing that I want you to think of is, what is a smart village? Can we create a smart village or a smart community in your area? So this will help bridge some of the healthcare gaps. So the start with this initiative simply is some interventions at the facility level, community level, and institution level, using frugal technologies. One, it can be, because every medical college should have a rural outreach center. So can we create this rural outreach center as a platform for the medical students to work, which includes capacity building of students and faculty. Referral linkage, how do you establish referral linkage from primary health care to secondary care, tertiary care, and backwards. And so create a cadre of digitally enabled people.
So then we can have digitally enabled clinics, electronic decision support systems, point of care devices, and digital training of staff, and digital surveillance, because we need to look at what happens in the future to plan. But at the community level, we could have a lot of things. We can improve digital literacy, health seeking behavior can be improved, community needs assessment can be done. We can provide home-based assisted telemedicine. Remote monitoring can be done. I mean, people, one of the biggest reasons why people die is because they have hospital-acquired infection. Can we avoid people going to the hospital and provide remote care? So these are some of the futuristic thinking that we can do. Maintain digital health records and several other aspects. So this is my last slide, I think. So just to end with a lighter note, there is this patient who lived till 102 years. So he was asked, how did he manage to live when he was 100? He said, do not smoke, even for the fun of it. Eat plain food, lots of beans and vegetables. Do not drink except for a little while. I mean, that's a wrong advice I can give here. Work a lot, work hard physically. Do not be concerned over politics. Avoid courts and doctors. Do not read newspapers and remain illiterate. Now maybe we should say avoid TV. And sleep plenty and sex do your best. But when we asked a woman, she lived till, this is a real story, she lived till 109 years in Scotland. She was asked the secret to longevity. She said, eat your porridge and avoid men. So for women, it has to be, they have to avoid men, and men have to avoid politics. So I'll just leave you with this quote. This is Toni Morrison is an African-American author. She wrote an iconic book called The Song of the Solomon. It won a Booker Prize. That she said, if you don't create the future, the present extends itself. We have to avoid that. And we need to think of innovative ways of improving health of the population through healthcare innovations. And I like this poem by Robert Frost, which says, two roads diverge in the road, and I took the one less traveled path, and that has made all the difference. Thank you very much for listening.
Thank you so much, Dr. Saw. It was really enlightening. I could visualize being a digital citizen that the day is not far off when I think we'll have our health system connected with our Aadhaar cards, and the system would be like we have complete digital history of our health right from the birth. Whenever we visit the doctor through vaccinations, and everything would be digitally available. And any doctor can just see our complete history on a click. So it will be a centralized data of health resourcing. The way we are growing digitally, I think India is going to be far leading the world with doctors and thinkers like you. We are really lucky to have you here today. I hope you all agree. Not taking much time, I would request people to have any questions and answers to Dr. Saab.
Good evening, sir. So my question is, can we prevent RHT with medications? If yes, then how long, and what are the precautions we should take to avoid the surgery?
In rheumatic heart disease?
Yes.
Yeah. You can prevent rheumatic heart disease, especially in the earlier years. When people get rheumatic fever, they are advised penicillin injections. First is what we call as primary prevention. That is when people have sore throat, to provide them with treatment if it is bacterial meningitis. Subsequent to that, if people develop acute rheumatic fever or even mild valvular lesions, we advise them to what is called as a secondary prevention, penicillin for 3 weeks. If they are unable to tolerate, there are other medications that we give like erythromycin, etc. So we will be able to prevent
even despite that, even if people have continue to have valvular lesions, we should avoid getting infected, or what we call as infective endocarditis, and there are certain precautions in that. So it's a long story, maybe you should ask for the wonder.
Thank you, sir.
So, very enlightening talk. You touched on 2-3 points which are environment, just mentioned. Where outside environment. You are sitting with the community which is 41st in terms of air quality in the world. We are having a very bad air quality and preventable. People like you who are in the advisory role and are being heard. I think we should be having more interventions with the municipal government to have good air spaces. We have parks, but next to it is a road which is choked with vehicles, spewing all kind of carbon monoxide plus. So you need to intervene that let's have some clean air zones where people park their cars away from that place and there are no vehicle zones. At least when people go in the morning, they have a clean air to breathe. Sorry to say, I have been using an air purifier at my home in November. In the morning, the air quality is about 400. And in the evening, it comes down to 250. So thereby giving me an indication that it's better to walk in the evening rather than the morning, which everybody does in all places. So I would like you to, I'm speaking of only air, I would also like to speak about water. Water quality, we have yet not done a study in cities like most industrialized city of Ludhiana regarding water pollution. How much cancer has been caused, how much diabetes has happened because of these chemicals being thrown into the water or reverse poured into the aquifers of the city. So we need to work, when you're talking about community, I would like you to highlight this at the government level, because we are too small in terms of having policy interventions. That's my point.
Right, sir. I think you're giving too much of importance to me. You think that the policymakers...
I think your center is doing excellent job.
Right. So, whenever you go to policymakers, one of the questions asked is, where is the evidence? That is why we wanted to generate the evidence in terms of air pollution. The big problem about air pollution is nobody believes the data because it's model data. So you have to create a robust model and validate against real measurement of air pollution. So that's what we did. What we did was we obtained data from the monitors in Delhi and Chennai. We obtained data from the satellite. The satellite goes around the city every day and we get aerosol optical levels. Third, we use emission inventories from thermal power plants, from brick kilns even around the city. Then we had to adjust for greenness, which you rightly pointed out. Green areas have less pollution. So greenness, parks, then transport infrastructure, metro infrastructure, land use patterns, how closely the houses are clustered. So all kinds of things we had to adjust, and it really required a supercomputer. We had to buy that because the analysis takes a lot of time. Just for the city of Delhi, we had around 4.2 million observations, and we obtained data of PM2.5 every day from 2010 till 2016. Now we have gone up to 2020, but we have created an air pollution model for the entire country now. We're going to put it on a dashboard anybody can use. Secondly, in terms of Punjab itself, we are working with UNDP in terms of what would be the return of investment. Because air pollution is not a homogeneous entity. Ludhiana city, the reason for air pollution may be different from Delhi or from Chennai. Right? So we need to find out. So for the city of Amritsar, we are doing return of investment, looking at where should they invest in energy sector, should they invest in construction sector, should they invest in hospital sector. In fact, in the US, 8% of the greenhouse gases comes from the health system. Because 3 reasons: food wastage, which
which releases methane. Second is waste disposal, improper waste disposal. Third is supply chain. Where are we doing sustainable procurement? So even where we can do some simple things, we can gain. So that's the kind of modeling we do, and we submit it to the Punjab government for them to work. One of the things that we have been saying is that crop residue burning, but it does it for 2 weeks. And in the winter, people burn leaves because they have to have warmth, so they will burn fire. So are there some other alternate mechanisms? Second is, though many states have become surplus with electricity, people are still using generators with diesel. So why, it's a government which provide electricity to everybody. Nobody would invest in a diesel generator. So these are the kind of systemic problems that are there. And we have been writing about it. Lastly, sir, the health impact assessment has not been done very well. That's one of the things which we have assembled various cohorts in the country. We are trying to link with various diseases. Sorry.
Good evening, sir. Thank you for the nice talk. My question is, we have spoken about the digital technology part. So when it will be available, by which time it will be available to the community for this purpose?
Right now,
And right now, is it in any of the hospitals or any of the places over there? Thank you.
so the government of India actually has what is called as a NCD prevention program or NCD policy. In that, they have put as an aspiration, and they have mentioned our program that it will be included across the country. So the idea is there's already e-Sanjeevani which the government uses, but e-Sanjeevani is what you want to call as electronic health record based, but it needs addition of this decision support system. So they are working on it. So government will have it maybe in 2-3 years' time. Whereas in the private sector, people are already using electronic health records in many of the private institutions. All is required is political will and the will from the doctors to use digital technologies. Because the fear from the doctors is their autonomy gets compromised. That's not true. In fact, it allows them to practice the art of medicine rather than wasting time on routine things. So it will take some time. I didn't feel the answer. It will take some time.
We have a question from one of the members, Mr. Jitendra Sood. He says, respected Dr. Sir, in your slide of myths, can I add up one thing? Every second or third person is taking aspirin of his own. How far is it useful or harmful? Please advise.
So it's a very important question, and doctors also have been mulling as to whether normal is. So there have been numerous trials that have been conducted. It has not been shown to use. It reduces heart attacks, definitely to some extent, but it increases bleeding, it increases stroke, it increases hemorrhage. So it nullifies the benefit that you get. So if your risk level is very low, so there are these risk calculators that are available. If your 10-year risk is lower than 10% or so, I would take aspirin. If it is very high, maybe about 20% I would take. Second thing is, beyond the age of 70 years, if you're perfectly all right, you have no risk factors, nothing, please avoid aspirin. It can be dangerous. If you reach 70 years without any risk factors, you will live longer without aspirin.
I have one question to ask you. My question is very simple and a layman's question. The time we were kids, we used to have just one doctor who's an MBBS, and we used to get all the diseases cured by him. Now there is a large advancement in medical sciences, and I just want to keep fit because it's very difficult to find out to which doctor to go. So, basically, when you go to one, I have my old parents living with me, and if they have some problem, I go to one doctor and they will tell, this is okay, but you just consult a cardiologist. Then you go to the person who is diseasing with the stomach. I'm just confused out of all this. How to deal with this one? This is my one question. And I'll ask the second question also.
So you want me to answer this first? I wish I had an answer for you.
Yeah.
But the answer is,
that we require family physicians and general practitioners because they are the most powerful people who actually have the knowledge. Unfortunately, what has happened is, like in any experts, any individuals, we need to create T-shaped individuals. The horizontal limb of the T represents the breadth of knowledge. And a general physician should have the breadth of knowledge. And the specialist should have the depth of knowledge, which is the vertical limb of the T. But what has happened really is our training has been poor. We have focused more and more on specialization. And that's where the problem is. It's a systemic problem. So I have no particular solution to what I'm saying. But if you find a good general practitioner or a general physician, he or she is like a gold dust. Keep it safe.
My second question is, I've been asking this to many people, and luckily the two leading cardiologists of Ludhiana, they are sitting here. People say when we are using ACs, we are decreasing the inside temperature, and we are living in a closed room. We are inhaling oxygen and exhaling carbon dioxide at the same place. We are increasing the concentration of carbon dioxide inside the room, and we are making the life of the plants and animals outside the room difficult with the increased temperature. How far do you think that this ACs are very necessary for life? I find that all the hospitals, they are also centrally air conditioned, and now the thing is, people have just removed the doors of the windows. They are putting just fixed glasses. They are converting the houses into cages. So how far do you think that this is good for health?
So the thing is, AC is for comfort. Whether it's good or bad for health is a question that we have to see. As long as we don't allow fungus to accumulate or something to clear the filter, people who are residing in the AC room are okay. Your point about people are living outside the system where heat is generated. One of the reasons for global warming is obviously AC because it emits such high temperatures, and that's a problem. So we have to make more efficient ACs which doesn't give out that high degrees of temperature. In fact, there are people who are working on cool roofs for people who cannot afford ACs. There's a group called NRDC which has installed cool roofs in Jodhpur, which is one of the hottest areas of the country, and it really works. So, I mean, once we get some frugal solutions like that, which can be scaled, which will be attractive for people to use, we are stuck with ACs.
I mean, we should use ACs if they are beneficial to health, to our health, and then find hardly matters outside the room somebody's what happens to the other people who are outside the room. But if it's not that useful to us, to the health, because you are associated with the research in medical sciences.
Let me give you the example of what happened in Paris and Canada last year, a few years back. There was a heat wave in Paris, in London. A lot of elderly people died. So clearly there is a need for cooling systems, be it a fan, because some of these places do not even have a fan there. They never experienced temperatures of 30 and above. We have written a paper which is going to be published about heat waves, what happens in terms of heat waves. And what we have observed is when the temperature suddenly goes up by 5 degrees, be it in Shimla where the average temperature is 30 and it goes to 35, the number of deaths increase. So clearly a cooling system is required, particularly when you have temperatures above 40 degrees, which is considered a heat wave situation. And so most of Delhi, Ludhiana, North India, we have that in summer. So ACs, I'm not saying AC specifically, I'm saying some type of cooling system is required. Whether you're using air cooler or whether you're using ACs, but we are having more and more efficient ACs, which consume less electricity, which are much cleaner technology. So, till we have some better solution, we will require ACs, particularly for the vulnerable elderly population or people with heart diseases.
Yes,
So that would be the last question. Yes.
maybe last,
Yeah.
because it's a matter of heart attack or cardiac arrest.
Perhaps a few days ago I saw in social media, YouTube, I forgot the name of the doctor. He was telling that in case of severe heart attack, he gave 3 options. The other 2 I have forgotten. One was the aspirin plus something. The other was. The third was really, I say, funny or whatever. He said have 2 or 3 lal mirchis. He was the MD minimum. I have forgot his name. How far it is true. And then he was explaining something. Yes, it can help. Can it really help?
It cannot help. So, don't go by.
And Dr. said, please keep it ready. There's three different doses. One was aspirin plus something, another was also, that was standard medicine, homeopathic. The third was this. You keep the 3 that which is ready, and this is one of the alternatives. Is it? मैंने सोचा मेरा तो दम नहीं निकलता फिर भी निकल जाएगा. That's why I'm asking.
So maybe it's preventing them from a heart attack or something else. So you have to be very careful about social media. Please get it verified by somebody whom you trust. For purposes of publicity, people do many things, and this is one of them.
Why is that you keep coughing?
That's important. Keeping coughing. Suppose you have a heart attack-like situation and you feel dizzy. It may be because of irregularity in the heartbeat. Coughing is very helpful. In the cath lab, we do it when patients get, we ask them to cough. So coughing, yes, it's helpful.
I think the poor oral hygiene is also very connected with the heart failure. So, what is your take on that?
Oral hygiene has been linked, especially gingivitis has been linked to diabetes and heart disease. It's again related to the microbes in the mouth, and there are some other mechanisms. Irrespective of whether it is related to the heart or not, it's very important to keep the oral hygiene. Particularly, you have to spare your spouse from foul smell. So for that purpose, at least we have to keep the oral hygiene.
Looking at the paucity of time, we will be moving forward, and definitely we will be organizing another session on handling the emergencies, which we are going to have very soon, handling medical emergencies, again with the help of the MC Hospital. I would request Dr. G.S. Wander, Professor and Head Cardiology, here at the MC Heart Institute, to give away a token of gratitude to our guest speaker. I would request Dr. Vishnu Mohan to join in, please. Thank you so much, Dr. May I request Mr. Neeraj Jain, President Ludhiana Management Association, to give away the presidential remarks, which will be followed by a vote of thanks by Ms. Harpreet Kaur.
Good evening, ladies and gentlemen. We know the lifestyle changes which are happening last couple of years, the tensions, pressures, the dietary habits, or our work pressures, the pressures in our professional, personal life and everything and all. And somewhere in our heart or with our close groups, we always keep talking. Things are not good. There are so many heart attacks happening, so many diabetes happening. And every day we listen to someone younger dying or someone younger having a heart attack. This gives a concern. At the same time, if you look at the data together, I think there's a bigger cause of concern for all of us. So first of all, I think we had a great authority on the subject, Professor Dorairaj Prabhakaran, who's given all the data, all the research work which is going through for the last couple of decades of his professional career. And I think the things are looking very, very scary for the entire world, especially for India as well. So first of all, thank you, Professor Prabhakaran, for sharing this data, and I'm sure the data gives us an indication that it's a big issue, and we have to work on this as an industry, as a citizen. As a good citizen and a good corporate citizen, it's our responsibility to look at what more can we do to avoid these kind of things, or to help the society to reduce these issues and concerns which are otherwise going to be a big issue for not only for India but the society in general. And there are lots of simple ideas is given which are known to us, but at the same time, I think time and again we keep requiring to push ourselves for a better diets, for a better exercise, yogas, whatever way we can help ourselves and our employees or our colleagues to work on so that they can be better in terms of their health. I recall a couple of years back, Sachit started this Movina company where he started motivating the people or started awarding the people who could reduce their weight or who were better fit. At the same time, he was penalizing people who couldn't reduce their weight or who were of the same category. So I used to be feeling a little difficult maybe 10 years back, why is doing all these things as an employer. But his concern was always, unless we keep motivating our team, we keep pushing them, can we reach the right level? How can we improve our loyalty for the people as well as their improvement in health, which should help the society in general. So great data, great research work, and lots of flexibility in terms of the digitalization which is available, but I think more than that, my take is it's more your willpower and your thoughts. Once you decide to do that, I'm sure there are ways of finding out the time as well as the right ways of becoming better and more fit. So thank you very much, Professor Prabhakaran, once again for coming here, sharing your thought process, and I'm sure as industry, it's our responsibility to keep looking at the right environment, not only internally, but I think externally also in terms of pollution, air pollution and other things. At the same time, keep organizing the various camps where the more awareness of these diseases and the ways possible to reduce this could be introduced or could be keep on giving this ideas to the employees so that they can become fit. And I'm sure once the employees knows, they'll spread the same message to their families and their extended friends also, so that as a society we keep improving on this issue. As a country, we have seen the data, it's a concern, but I'm sure the way the government is working, the way all these ideas, the way these data and the publications are coming in, it's definitely a great help for all of us to conceive and to start working on these. So thank you very much once again, and I'm sure all of you have taken the full advantage of this session. My request to all of you to keep thinking and keep working on this so that as human, as society, we can do better than what we are doing. So with this, thank you very much once again, and I request Sakri to give the vote of thanks, formal vote of thanks for the same. Thank you.
Good evening, everyone. I'll keep it short. Since Dr. Prabhakaran has taken up so many studies today, I thought I'll just conclude the day with one more. So there's also been a study about people across the globe who've had the longest life. There are communities in Latin America. There's a community in Greece on an island. There's a community in an island called Okinawa in Japan, where about 1,100 plus people live on this small island. Unfortunately, 90% of them are women. You must learn something from us. we stress less and live more. But having said that, there are loads of things that came to my mind today, about how these 100-year-olds have no furniture at home, for example. That means they get up every time and they do about 30 squats a day, or they eat this purple sweet potato, or lots of things which probably Big Basket will end up selling you for 3,000 or 4,000 a kg. But there are so many revelations from this simple lifestyle. No ACs, I'm missing the lady now here. Not even reading glasses at 100. So amazing how these people are living a very simple life, going back to where we were. And maybe that's where the answers are. We have so many questions we look at, but the answers are very simple, I feel. It's so nice that you could all join us today. Lucky to have some cardiologists and lots of doctors in the forum today. Thank you so much. And most importantly, thank you so much, Dr. Prabhakaran. You've made it a very special evening and an educative one for all of us. Please join us for dinner and drinks. Good evening.